Good afternoon. Welcome to the UCSF Department of Medicine Medical Grand Rounds. Welcome to our live audience here at UCSF in the Department of Medicine, our other colleagues at UCSF throughout the various schools and the campus and the health system, as well as our partners in the UCSF Health Network. I see we're already up to about 600 viewers, which is terrific, who have joined us. We will also post this video later today on Zoom. The two previous Grand Rounds that we've done in this format have received about 100,000 views, which is really gratifying. So it demonstrates there's a desire for up-to-date, accurate information, and we hope to continue to fill that desire today. The prior Grand Rounds, if you are interested in them, you can search on the UCSF School of Medicine YouTube account, and you should be able to find them. None of the speakers today have relevant conflicts of interest. A few quick ground rules. Sorry for the siren in the background. A few quick ground rules for our live audience. I'll hold on for a second. There we go. You'll be on mute throughout. If you have questions, please submit them through the Q&A button at the bottom of your screen. My colleague, Quinny Cheng, will be monitoring the questions and pitching some of the most common questions to me for our speakers as we go forward. Our format today will be a little bit different than the prior Grand Rounds. There'll be just a single lecture, that by George Rutherford, covering the shape of the epidemic both in San Francisco and around the country and the world. We'll have a Q&A session just with George. And then we'll have a 30 to 40-minute panel discussion involving three other experts from UCSF focusing on various aspects, including leading the command center, the use of technology tools in COVID, and being on the front line in our emergency department. The whole session will last about an hour and 15 minutes. Continued hats off to our community here at UCSF, who have been spectacular throughout, the clinicians who are taking care of the patients that we have with COVID and taking care of all of our other patients in all sorts of new and remarkable ways. We feel very grateful out here. Obviously, the disease has had a toll on all of us, but we have dodged the worst of it. And hearing from our colleagues in other parts of the country, particularly New York, demonstrates how bad things could have been. We've gotten very lucky here, in part because of really terrific leadership by our political leaders and our leaders throughout the city, including at UCSF. Also, thanks to our staff, to our research and educational communities who have also been massively disrupted by this, but are carrying on really quite beautifully. So with that, let's go ahead and get started with the first speaker. The first speaker is Professor George Rutherford, who's a professor in our Department of Epidemiology and Biostatistics. He serves as UCSF's Medical Director of Prevention and the Prevention and Public Health Group. His research focuses on the epidemiology and prevention of infectious diseases, and that feels pretty relevant to the situation we find ourselves in today. So George has become one of our key go-to people to tell us about where we are and probably just as importantly, where we are going. So let me hand it off to George and look forward to hearing your comments.
Thanks very much, Bob. Let me just get through this so we can get to Q&A, which I think is what most people are interested in. May I have the first slide, please? Or the second slide? Well, I just want to remind everybody why we're doing this and why this is, everybody like me is so worried about this. This is a curve of infectious disease mortality in the United States in the 20th century. And far over here on the right, you can see what the contribution of HIV. The other big noticeable thing is this huge jump here, which is the 1918-1919 influenza pandemic caused by H1N1 influenza, a new isolate. That's what we're worried about. You can see that the mortality approached 1% of the population of the United States, 1,000 per 100,000. The next slide, please. So this is where we are today with about approaching a large number of cases, approaching 1.5 million cases worldwide, with continued activity in Europe, although it seems to be getting slightly better This large outbreak in the United States heavily focused on the eastern seaboard after an earlier outbreak kind of back in this part that was in the state of Washington. So that's where we are. Now, I think what we have to realize is that we see very few cases in Africa, and we've seen very relatively few cases in Central and South America. And that's going to be the fertile growth ground for this going forward. The next one, please. This is where we are in the United States with a large focus here in the tri-state area of New York, New Jersey, and Connecticut. There's outbreak now in Boston, Detroit, Chicago, New Orleans. And given that the southern states were somewhat less brisk at going to shelter in place, I think we would likely expect to see some increased degree of activity across the large southern cities. You can see some of it down here in Florida, already a little bit in Atlanta, Dallas, Houston, St. Louis. There are a handful of states that have not gone to shelter in place yet. For California, prime among those is Utah. We live in Northern California, don't quite feel the influence of Utah, but there's a ton of back and forth between Salt Lake City and Los Angeles, and that's a worrisome thing for the future. The next one, please. So what are our goals here? What are the public health goals of this? First of all, we want to minimize transmission of this virus. And by minimizing transmission, we minimize mortality. We also want to avoid overwhelming the medical care system. There are data from Wuhan in China and also potentially from Italy that the more overwhelmed the medical care system is, the more the proportionate mortality rate goes up. So a system that's struggling at the edge is going to have proportionately a greater number of deaths than a system that can accommodate people and really be able to sort of fully pay attention to every single patient. We also want to return to, as the executive vice chancellor and provost says, Dr. Lowenstein, to the life we aspire to. This is a euphemism for back to work, but it's the life we aspire to. And then we want to contain transmission until a vaccine's available. So the next slide, please. So we're sketching out our ideas, and the next one, please. Thank you. One before, please. So we're sketching out our ideas. Can we go one back, please? Yeah, perfect. For what do we need to do here? And these people are putting these lists together, and they're looking remarkably similar. It's not often that I agree with the American Enterprise Institute, but we seem to have come at it at about the same place. First of all, transmission needs to be low. And by low, I mean low, low, low. We have to have a low number of new cases that are reported. We have to have a low number of hospital admissions. We're going to go ahead and try and measure incidence in cohort studies. Doctors Havler and Greenhouse has a series of studies that are looking at trying to measure seroprevalence, and we fully expect that their seroprevalence estimates will be kind of consistent with what we're expecting with quite low prevalences. We also want to look at a variety of sentinel surveillance systems. Dr. Greenhouse has just begun a program of looking at remnant specimens from the UCSF and Zuckerberg San Francisco General Laboratories to look for cases with antibodies to look for kind of background rates of cases of COVID-19. We're also trying to get data from a commercial entity called Kinsa to do fever surveillance. These people sell thermometers, and they have a big data set that will look at trends in fever over time. Mark Pletcher has been a huge help, and he has put together a surveillance system for cough and fever based on a platform that he and his colleagues developed for cardiovascular disease symptoms around the country. So those are all kinds of things that we're looking at. The second big thing is that testing must be available essentially on demand. And it's not just for people who are symptomatic, but it's really people whom we need to test. So that when we're doing contact tracing, for instance, we want to be able to test negatives, people who are asymptomatic as well as people who are symptomatic. We have to have in place a vigorous contact tracing system with supervised isolation, supervised quarantine when need be. And this means having space for people who need to be isolated and quarantined and can't do so at home. And fourthly, we need to have an adequate hospital bed, ICU, ventilator capacity. The fifth thing, and this is not on most people's list, are what are the other things we need to do besides these other four? What do we need to be assured of besides these other four? We need to continue to have social distancing. And how are we going to do that? There'll be continued restrictions on mass gatherings. I don't know this is a fact. This is my surmising. Sheltering in place, but possibly for older adults for a while. That we'll continue to want people to wear masks outdoors. We will likely stagger return to work, which is something that the Chinese have done, where they divide their workforce up into groups and they try not to have overlapping hours. So half the workforce, for instance, works like I'm making these numbers up, 4 a.m. to midnight. The other 4 a.m. to noon, and the others from noon to 8 p.m. You know, it's that kind of thing, so we can have separate cohorts. And then I put down options for schools. Obviously, schools are a big concern, and the influenza A model is that children transmit influenza A rapidly and are big incubators for disease in communities. I think there are some ideas about how to sort of safely introduce kids to school. That doesn't involve testing them all and cohorting the ones that are seropositive into one group and the others who are seronegative into another. First of all, seropositives we think are only going to be about 1% of the population, so that's not a really practical kind of a solution. So we're going to have to figure this out, and I think there are some options that we'll continue to look at across the summer. The next one, please. And just to walk you through some of the data quickly, the next one, please. These are San Francisco's putting its data up. There are 676 cases in San Francisco and 10 deaths. Last Thursday, was it, Bob? Bob will know this. Columbia Presbyterian Hospital had 724 patients on ventilators. So you get an idea of how much difference this is. There's been a lot of discussion of race and ethnicity. The race and ethnicity for California cases is roughly parallels the race and ethnicity of the state as a whole. No one's published race and ethnicity data for deaths yet. The next one, please. This is where we are. It's a relatively flat curve. I wish I didn't have to look at these last 3 days, which I always worry about, but I suspect we're going to bounce around here at around, below 50 deaths or right around 50 deaths for the next little while. This is a flat curve.
George, I think you mean 50 new cases. 50
new cases, yeah. Sorry, okay. I beg your pardon. 50 incident cases. So this is kind of where we're bouncing around right now. We're now 3 weeks into this pattern, and it looks pretty flat to me, although you never know what's going to happen. Right? The next one, please. This looks at ICU and acute care bed usage, which again is relatively flat over time, especially if you look at exponential growth in other places. The next one, please. So what are we trying to do? This is from the lessons from the 1918 influenza pandemic, where you can see this quite flat curve in St. Louis, the red line. That's one lesson, and we have basically replicated that lesson. But look at the back half of the red curve, where they let their foot off the brake too soon and got a bounce up in mortality. That's something that we have to time well to understand exactly how whether to avoid that. The next one, please. The next one, please. So I've shown you this slide before. I had a particularly enterprising medical student who's was able to read enough Italian to run these series out all the way to the present day. And you can see this province that went to shelter in place early versus one very nearby that did not. You can see these huge differences that have persisted. And the next one, please. And when we superimpose these on San Francisco and Los Angeles, it looks not dissimilar to that experience. Los Angeles went to shelter in place 3 days after we did. But if you'll notice out here in the last week, It's been relatively flat-ish in Los Angeles as well, and that may be the consequence of their shelter in place. So we'll see that the rise was about going to shelter in place later, but when it's flattened out, that may be the consequence of them sheltering in place. The next one, please. This just looks at the same thing in Southern California versus the Bay Area, so you know we're not pulling your leg and leaving data out. And the next one, please. Now, I have 3 people who've been working with me, a 4th-year medical student who was supposed to be on a CDC rotation this month, Shah Radari, Mia Kanzawa, who's a first-year preventive medicine, internal medicine resident, and Hillary Spindler, who've been really hugely helpful. This is Mia's. She went and found open table data about what were trends in restaurant usage as we were starting to move to shelter in place. And you can see San Francisco here was moving away from congregating at a faster pace than this is compared to last year than New York and Los Angeles. So this is us down here, and you can see how we're backing away. Part of it, as Janet Washitsky from Pediatrics points out, is that Bay Area employers began telecommuting earlier as well, with Salesforce, Apple, Google, and Twitter pushing people out of the offices and having them telecommute, which may have been huge in all of this. The next one, please. We also have syndromic surveillance. This is from the temperature thermometer company. We're not, it's not staying in the range, so that's good. And this is the Mark Pletcher's citizen scientist platform. These are just people from San Francisco. This is an N of about 1,000. So, fever and chills is kind of up in fever chills. I'm sorry, these are backwards. Fever and chills are down here at the bottom. I'm sorry. Fever and chills are up here in the blue, and down here at the bottom are fevers and chills and a cough or shortness of breath. These are all fractions of 1%. So we're not seeing any kind of big numbers from this. And I think that may be it. One more, please. Oh, and this is just the amount of testing in San Francisco. We're running about 13 overall, about 13% test positive, which has been a pretty consistent number. And then one more, please. And then this is just the new estimates that came out yesterday from the Institute for Health Metrics and Evaluation. I realize this looks quite small. This is a slight modification of the one they put out last Sunday night. This says the peak in California, which understand as part of, it's a blend of Los Angeles, the Bay Area, and around Sacramento, that the peak will be on April 13th with sufficient beds and ICU beds statewide to accommodate it. I actually think that we're kind of, we're going to be a little bit ahead of Los Angeles in this, but these are what the latest projections people are looking at. So with that, I'll stop and answer questions.
Thank you, George. That was terrific. I think the questions are still coming in, so I'll start. I've got about 1,000. So the governor of California has said publicly in the last couple of days that our peak won't be till mid-May, and you are saying mid-April. Why is there a difference?
I'm saying that the Institute for Health Metrics and Evaluation said mid-April. I think it's actually early April. They are using, I think, we've started to pick their models, the state models apart. Alameda County's freaked out by this, as you might have met, by the state models. And we're specifically looking at that. We think they're based on fairly kind of early on models, this CHIME model from your alma mater of Penn. And I think that's, I think they're overestimating, and I think they're kind of pushing it back too far. It all remains to be seen, but they're different models than the ones we're looking at.
Okay. Why are we still having 50 new cases a day? So we're now out beyond the window of a case now, I assume, would have to have gotten infected after shelter in place. The streets of San Francisco seem pretty empty. So the cases are stable. If anything, as you say, the last couple of days have seen a slight uptick, although that might just be noise. Where's that coming from?
So there are 3 or 4 places that it can come from. First of all, it's going to come within households. People, there have probably been multiple chains of transmission in households, when people went to shelter in place, someone was infected. They infected roommates or housemates, infected another house, and so on. That's one thing. The second thing is that there is, we have healthcare workers who come in, not at UCSF, of course, but who come into other institutions and may become infected, and they represent some, and can also go back and transmit. We also have people who have not been as faithful with sheltering in place as others, and they could represent transmission. And finally, we have people coming in from the outside, especially from out of state, and who could be incubating and transmitting as well as they move into a household and start to shelter in place. There's always going to be some, but the trick is to knock it down as far as you can. Plus, we're having more testing. And I think some of that bump up may reflect just more aggressive testing.
Okay. So let's assume that the curve that you showed is right. It looks like we're down to minimal numbers of new cases by early to mid-May. Testing capacity is ramped up. Contact tracing is ramped up. So is that's the time that we would say, all right, we're now moving on to a new phase, and take us through that in a little more detail. Does an order go out to say you can leave your house, except somebody like me who's over age 60, I need to stay home? And in terms of going to work, is that, are we beginning to fragment the population as to different risk groups, and you can do this, but you can't do that?
So we've already fragmented the population into essential and non-essential workers, and I assume, Bob, they consider you an essential worker, but
mostly not. Yeah.
So this is not my office at UCSF, by the way, just in case you were wondering. So I'm staying home. It's a real complicated question, because we have all these states that haven't done this, and we're at risk for importations when that starts to happen. I laid out the criteria that we think are applicable to moving away from shelter in place. I know Diane Havler is also working on a very similar document. But I think whatever we decide is going to have to be informed by understanding exactly what the transmission rates are and the transmission dynamics. What is it going to look like? First of all, we have a statewide order that doesn't have an end date on it. That would have to be rescinded. It could be rescinded piecemeal. The local health officers may, if it's rescinded, the local health officers may choose to put out a new order, a new set of orders that are modifications. I suspect, especially around mass gatherings, I think that's going to be tough to pull off. But I think we'll just have to see how it plays. Again, it's going to be really decided at the governor's level.
Okay. And one of the questions came in, what can you tell us about the San Francisco task force being assembled to do contact tracing in San Francisco and the Bay Area? And as you sort of tackle that, just tell us about contact tracing. It always, it just, for those of us that don't do this for a living, like, how does it actually work?
So Dr. Wachter here has gotten diagnosed.
I have not, by the way, but thank you.
I'm just hypothetical.
It's a hypothetical, thanks.
Hypothetically here, Dr. Wachter's been diagnosed. We go out, somebody comes and talks to him, a case investigator will say, tell us where you were, and we can actually narrow down where you were when you were likely infected, and where you're likely infectious, and with whom have you come into contact? Who's living in your household? Who do you come into contact with at work, those kinds of things. And by contact, we mean, more than 10 minutes within 6 feet of each other. Okay. So it's not like going past each other on the supermarket aisles or anything like that. Then we would we'll contact those people and ask them to come in and get tested. We'll keep track of who they are. We'll keep track of their test results. And we'll get them to either go into isolation or quarantine, depending on the situation. If it's not a particularly close contact and it's and you wave to them out the window or something, just let them go if they're negative. If it's your, if it's your spouse, we would probably ask that she be quarantined for that 2-week period if she's uninfected. Right. So that's the way it's going to go down. And then we follow up. Now, if somebody would say we're homeless, we would get them into a hotel, and we might take their closest contacts, like the person next to them in a homeless shelter, and have them go into quarantine as well, especially if they're older and stuff.
And you said ask them to go into quarantine, and then earlier in your talk you mentioned something like forced quarantine.
I said supervised quarantine.
Supervised quarantine, sorry. Okay, tell us what that means and how one balances this sort of central tension in American life between individual rights and the public good in a situation like this.
So the health officer clearly has the power to have people go into quarantine, period, and can order it. We may issue, it's still under discussion with Tomas Aragon and Grant Colfax, but it may be easier for people to get out of work and stuff if they actually have health officers' orders in hand that they can show them. So that's a system we're trying to work out now. We'll just have to see how that plays out. We would obviously, there's not enough people in the world to sit with someone during their 2 weeks of quarantine. In Singapore, just to give you an idea how this goes down, they ping your phone at a random time of day, and you have to take a picture of where you are and send it back to them within 3 minutes. So if you're out, if you're out at your local bar, you got 3 minutes to get back to the hotel room. So, we're not going to do that stuff, but I think there are degrees of coercion that can go with it. There's an article, I believe, that's coming out today in the New England Journal that talks about coercion and voluntarism in quarantine and isolation.
Okay. In terms of the testing, are we talking about testing for virus, testing for antibodies, testing for both, and how do you make that call?
Sure. So antibodies, at least as it appears now, do not become measurable for at least a week, and maybe as many as 2 to 3 weeks after infection. So we're still talking about testing with the PCRs for viral RNA. Now, the wrinkle on this is that there is an emerging literature that says you can just culture the anterior nose and don't have to do the nasopharynx. So that kind of opens up possibilities for home testing, although you're going to be mailing infectious things around, and home, mail out surveys and things like that. That's the new kind of wrinkle in the technology, plus rapid testing and all that stuff. I think antibody testing is going to be eventually going to be really worthwhile, but think of it kind of like our progression with HIV antibody testing. You remember early on, it was 21 to 35 days was the window period before it became positive. And it's gotten progressively shorter and shorter and shorter. And we now have combined antigen antibody tests. The window period is about 3 days, but it's still 3 days. Right now, the PCR window period is probably 3 or 4 days, right, for infection until positivity. That's probably about as good as it's going to get. We might be able to knock another day off of it. But with antibody testing being this far out, it's going to be useful for a handful of things, saying that someone's actually been infected if they need to somebody wants them to come back to work. I can imagine scenarios for seroepidemiologic studies, or finding people to donate convalescent plasma. I think is going to be an important, and I think that's going to be another important use of it. We're mostly concentrating on seroepidemiology in my world now, and we think it's going to be a very useful adjunct, but it's going to tell you what went on 3 weeks ago. Right, so you kind of have to do both of them together to get a complete picture.
Are we confident that antibodies equals immunity in this disease yet?
We're working on it.
Where are we?
Where are we working on it? Everywhere.
No, I mean, what would you have confidence today that someone with antibodies can go into a risky situation and feel safe?
If I had, I don't know it as an absolute fact, but I think that it's probably right. I wouldn't, if it were me, and of course, I'm like well under 60, as you know, Bob.
Yeah,
I would take it as gospel, but it's not, it's not a proven fact yet. And there are going to be some components of you're going to have to look for neutralizing antibody. There are parts of antibodies that are really important. Chancellor Hawgood has put together a working group between us and Stanford to really pursue serology and really understand about neutralization and long-term immunity. And I think that's that'll be a huge big deal. So the other thing that obviously we have to figure out is exactly that. And as we're pursuing vaccine, we have to understand the immunologic response and the protective response.
and I don't think you're a vaccinologist, but everybody says 12 to 18 months we will have a vaccine, and we're 30 or 40 years post HIV and we don't have a vaccine. So is 12 to 18 months the minimum and we hope we'll have one, or are we confident that we will have one?
So everything Dr. Fauci says, I absolutely believe. So if he says 12 to 18 months, I think that's the answer. Right? And he said 12 to 18 months back in February. Okay, so just so you know that the clock's ticking.
Mm-hmm.
I would imagine I'm just guessing, but I think we'd come up with a subcomponent vaccine aimed at the S spike protein, which is the attachment moiety. That seems to be a relatively straightforward thing. Now, the fact that it's, we're seeing it circulate around the world. We'll be dealing with different strains eventually. We hope it doesn't have to be like influenza where you have to change it every year, but it all remains to be seen.
Okay, and maybe my last question for you before we open up to our other speakers. This issue of asymptomatic people having it and being capable of transmitting it, how does that change the approach to the next phase? Do we have to be testing a whole bunch of people who are asymptomatic? This all struck me as being a lot more straightforward, a month or two ago when we thought that you had symptoms, and if you didn't, you were good.
Right. So if I were the king of some small island in the South Pacific, yeah, I'd test everybody. And there's this great example of an Italian town that just went through and tested everybody. We don't have that kind of we don't have that sort of resource. We don't have that. It's an unlikely scenario to be able to work out logistically. So we're going to rely on contact tracing mostly to pull in asymptomatics, plus people who think they may have been exposed. That's what you really want, is testing on demand.
Okay. All right. Thank you, George. That was terrific. And it's going to be fascinating. It really does strike me that the next phase is more complicated than what we've gone through so far, and much more nuanced and kind of individualistic. Let's bring our other speakers on. So just introductions. Russ Cucina is the Chief Health Information Officer for UCSF Health, and has been the co-leader of the COVID Command Center. He's professor in the Department of Medicine and Division of Hospital Medicine, as is Niraj Sehgal, who is Vice President and Chief Quality Officer for UCSF Health, and also has helped lead our Command Center. And Maria Raven, who is an emergency medicine physician and a health services researcher. She's Associate Professor of Emergency Medicine and Vice Chair of our Department of Emergency Medicine. So let's bring all of you on with video and audio. And I'm going to turn to Russ first, because I think Russ is the only one who has some slides. And Russ, why don't you take us through the digital innovations that have happened in response to this. There's been a ton of stuff that has gone on, and strikes me that digital may be one of the things that makes this different than had this hit 10 or 20 years ago. And been very interesting and actually quite exciting. So why don't you take it away?
Great, thanks very much, Bob. I appreciate the opportunity. I think most people saw this front page of the New York Times from March 27th, showing a very unfortunate statistic that was relevant that week, where jobless claims for the week that ended that day were so large that the y-axis failed them, even when accounting for the global financial crisis back in 2008. I have an equivalent slide where the y-axis fails us, but with better news. Next slide, please. We've had a video visit program at UCSF Health and affiliates for 5 years, and this histogram shows the volume of video visits since near the inception of that program up to the close of last month. And you see that very nice steady growth. Next slide, please. And then the month of March 2020, just blowing everything previous to that out of the water. Prior to COVID-19, we were doing about 2.5 of all ambulatory encounters as video visits. Even that number made UCSF Health and Affiliates the second largest video visit program by volume amongst academic medical centers, and the largest video visit program in California. And then over the course of a very short few weeks, we've converted to 55% of all ambulatory encounters as video visits. Next slide, please. This has been an enormous amount of work, primarily by the providers themselves, the physicians, the nurse practitioners, and their clinic staff, who have taken the available technology and really seized upon it to make sure that we continue to serve our patients as best possible, with obviously a ton of support from the Telehealth Resource Center, Linda Brannigan, Therese Chan-Tak, and the rest of that team. This is a histogram of the last 8 weeks, starting in February, showing total ambulatory volume. It does, of course, demonstrate a diminution in total ambulatory visits over that period of time, again, as expected, starting in the 2nd or 3rd week of March when everything began to change. But then in purple, you see how much of that volume is able to be replaced by video visits so that we can continue to serve our patients as best as we can whenever possible with video visits. What a resource that has been. I'll also show that notwithstanding the gigantic jump in video visit volume in the month of March, that didn't even really start there until the 3rd week of March. You can see 317 there. So when the data come out for April, I think we'll find an even more dramatic outcome. Next slide, please. This has also been something where UCSF and our affiliates out in the community have enjoyed that same benefit. I could cite several examples, but I think maybe the most remarkable is the Marin Health Medical Network, our partners north of the Golden Gate Bridge that share much of our information infrastructure now, including the Apex electronic health record and our video visit infrastructure. They went from 0% of their ambulatory care being video visits to 70% in the space of 5 days. So truly a remarkable service to that community by the Marin Health Medical Network, and just one sign of the success of that particular partnership. Next slide, please. We've also seen new models of remote care coming to UCSF. Bob, among others, has often asked the question, what would it look like at UCSF if we started hiring physicians or setting up entire practices to do purely video care, and what new models of care could that represent? Just in the last 3 weeks, that has gone from an idea to something that is now busy, with a lot of credit to Dr. Paul Nadler, Dr. Matt Sakamoto, Susan Smith, and others. We now have the UCSF Video Acute Care Clinic, or VAC, the video complement to the Screening and Acute Care Clinic, or SAC. The Video Acute Care Clinic is primarily providing rapid video evaluation of patients with respiratory symptoms to make that decision about whether the person's cough and cold type symptoms and the history of their exposures and how they may have acquired that constitute an indication for coronavirus testing. This has been a service to the community, but also in particular to our employees and our employee patients. It's been an important part of our UCSF Health's occupational health response in ensuring the health and safety of our workforce. We've also had, through the Office of Population Health, Gina Intinarelli and colleagues, very exciting work in home pulse oximetry. As I think most folks know, most patients who get COVID-19 don't have to be hospitalized, fortunately. They are at home with a very unpleasant, but ultimately for most patients, not dangerous respiratory illness from which they will recover. But an important way to monitor those folks and distinguish those having a self-limited illness to those that will require hospitalization is monitoring their pulse oximetry. So the Office of Population Health and others have arranged for us to be able to send pulse oximeters out to the homes of patients so that they can be monitoring their own oxygen saturation as an early indicator of folks that may not be having the hope for recovery at home and need to come into a higher level of care. Next slide, please. On the inpatient side, I think everyone is aware of the importance of personal protective equipment and the appropriate protection of clinicians and everyone else involved in the care of inpatients. And what an important issue. The stewardship of personal protective equipment has been at UCSF and everywhere else. So a program that had existed prior to COVID-19, but we've had a wonderful opportunity to expand, has been to create a video bedside for clinicians of all kinds. This is universally deployed up on the 15 long respiratory isolation unit, also very well deployed in the emergency department on the Parnassus campus, where a iPad or other piece of video hardware is in the room of the patient. And when it's appropriate, a clinician or anyone else who needs to speak with the patient and do an evaluation that doesn't involve a physical exam is able to do that using Zoom and interview the patient without having to don and doff and thus consume personal protective equipment. We're also using the same technology to provide video telepresence for family visitors. I suspect most people know that by order of the public health officer, it's been necessary to very significantly restrict visitation for patients in all of our care settings, but particularly the inpatient setting. And so we've set up the ability to provide video telepresence to make that at least a somewhat less lonely experience for our hospitalized patients. Next slide, please. I think next up for this is video support for the most severely impacted hospitals elsewhere in the country. As everyone has mentioned, we're incredibly blessed in California that through the actions of many, including our elected leaders, we are doing so much better than New York as one important example. There's a lot of work happening that I won't go into about the direct support of hospitals in New York by UCSF and others. But one thing we can also do is provide video support to those hospitals, and that's something that we'll be working on next. Next slide, please. I'll mention that one of the things that has made some of this possible is been significant emergency regulatory relief. Medicare is now for the first time paying for video visits. In California, we have the benefit of a very strong telehealth parity law that requires Medi-Cal and private payers to pay for video visits, but that doesn't apply to Medicare. One of the provisions of Congress's Emergency Relief Act was that Medicare is paying for video visits now, for now, unfortunately. We will all find out together, and I think the University of California will continue to have an important role in helping Congress see that having once discovered that it's a great thing to do to pay for video visits for Medicare beneficiaries, that will hopefully continue. Although the law, in fact, does say that that lasts for the moment only as long as the public health emergency does. There's also been some specific relaxations of HIPAA enforcement as long as the technologies are secure in practice. That has had some enabling effect, particularly on our inpatient video visit program. And there's been some relaxation of interstate licensure and enforcement. Next slide, please. I'll move along here quickly. We've also had the mass deployment of secure communication on providers' individual cell phones, with 3,900 providers getting Volt on their personal cells in the span of a week. Next slide, please. There's been a lot of advances in data information interoperability across the state and nationally. I think the most prominent example is that we're now able to share COVID-19 results essentially across all the major providers in the state of California, both for individual clinical care and for contact tracing. Next slide, please. And one more slide, please. There's a lot that we can say about new data visualizations that have come out with this, and so I'm just going to close with two examples, although I could cite several others. This is really exciting work by Dr. Logan Pierce, Dr. Liza Wick, and Julianne Sosa. This is the case depot and the wait times for high, normal, and low priority cases for those surgical cases that have had to be delayed in order to prepare our hospital for potential surveyed COVID-19 patients. As George mentioned earlier, there's important considerations about not increasing the non-COVID-19 morbidity during a pandemic. And so this new visibility and analysis of those data is being used to inform how we increase our completion of the most urgent cases as we find the curve remaining flat. And one more slide, please. And this is the COVID-19 executive dashboard. This is a Tableau visualization by Dr. Sarah Murray, by Rhiannon Croce, Laurel Gibbs, and others. What's exciting about this is we're going to be able to make these data, I think, widely transparent across the UCSF community. I think everyone's ability to see these data and understand how the pandemic is progressing, or better yet, not progressing, and the increase in our testing capacity, I think will go a long way to helping keep our community united in our work together. And then you'll see there's healthcare worker data coming soon. One of the things that we would like to make quite transparent is the health and safety of our employees, both the testing of our employees and those employees that have tested positive, and the best available information about their contact tracing. And we hope to have that available just within the next few days. With that, I'll stop. Thank you, Bob.
Great, thank you, Russ. That was terrific. Let's bring on our other speakers, Maria and Niraj. Let's throw one quick question to Russ, and then I want to move on. Gone from 2% video to 60-ish% video. Let's say magically COVID goes away a year from now, and what percent do you think will be the percent that we're left with?
Yeah, it's a terrific question. I've been using the analogy of the Loma Prieta earthquake, when the Bay Bridge was impassable for 2 months and everybody started riding BART. There was a massive increase in BART ridership, and then when the bridge was repaired, BART ridership dropped, of course, but it never returned to its prior baseline. It returned to a new higher baseline. I can't speak for the faculty practice office, but I suspect that we will have great conversations at UCSF Health about the video acute care clinic and whether that's something that should remain a permanent feature of UCSF. And I'm extremely hopeful that our providers and our patients, having gotten accustomed to video visits and realizing that they work well, it's a good experience, and it's not too technologically challenging, that we're going to see a return to a new higher baseline. I hesitate to pick a number, but I'm pretty confident that we are not going back to 2.5%.
Great. Maria, welcome. Tell us a little bit about the early days in the emergency department. I think it's easy to think about today, and things, again, we've been incredibly fortunate. Things are relatively calm. The early days were uncalm. A lot was happening incredibly quickly. I imagine it was scary down there. You had to make 100 decisions quickly. So tell us what it felt like, and things that maybe you hadn't anticipated.
Yeah, thanks for having me, Bob. It was quite a whirlwind, I would say, in the emergency department in the early days. I think one of the things that was pretty notable is that the medical center sort of writ large realized that we didn't have the capacity in our emergency department to care for a potential surge of respiratory patients, because we were already sort of at max capacity. So we were really appreciative. They quickly allowed the purchase of these 2 military-grade medical tents that we have deployed right now, which we call our accelerated care units. And those, they got delivered quite quickly. We got apparently the last 2 that were available in the nation. And they were put up and operationalized in about 4 days. So they were erected on Thursday. We had to get approval from the California Department of Health, et cetera, the fire marshals, and we were operationalizing them and using them on Sunday afternoon. So that was pretty unbelievable, and it took a lot of work from a lot of people outside of the emergency department at UCSF Health. So it was really nice to see everyone come together and really help us deploy. So that allowed us to sort of cohort our respiratory patients if we needed to, and alleviated some of the worry we were having about having potential COVID patients sort of in our hallways of the ED, which also put our healthcare workers at risk, obviously.
Yeah. How much fear was there among the healthcare workers, and how did you manage that?
Yeah, it's interesting. I think a lot of us were working so hard to get things operationalized and off the ground, we almost didn't have time to get to have much fear. Wasn't until we stopped, maybe a couple weeks later. I think a lot of the fear was around PPE and the availability of PPE. So we've tried to sort of really focus on that for our healthcare providers and have pretty stringent policies. So very early in the game, we had a mask and eye protection policy for every single person in the emergency department. There was a short time there when we were all in like full airborne PPE on a day before the ACUs were operational, when we had some patients in the hallways. But we've been pretty vigilant around our PPE use, and I think on the sort of outer edge of the information we're getting. The one other thing I'll say is that we have a platform that we use as our source of truth for our emergency department called Elemento, which we update literally multiple times a day. So every single bit of information we have related to COVID is on that platform. And so I think it helps people to know that all the information is there and very up to date.
Tell us a little about what you've seen clinically. Are typically the patients who come in with COVID, are they sort of not that sick and they're in the early phase, or do you see people in extremis and need to go right to intubation?
Yeah, we've seen, so I think early days, it was a combination. We were seeing a lot of people in our ACUs. So we were pretty high volume initially, you know, kind of in the high 30s to 40s per day. And so most of the people in the ACUs are lower acuity, just people that kind of maybe have a little illness, need a chest x-ray, a little bit of a workup, and can get tested and go. That volume has dropped off drastically, as has our overall emergency department volume, so that now the majority of patients that we're getting are quite sick, I would say. We also basically at this point consider every single emergency department patient a person under investigation, or a PUI. So we sort of just go under the assumption that codes that are coming in and that sort of thing are all COVID positive until proven otherwise.
And in terms of the decision about who can go home, given, you know, what we've heard about this illness, which is, you know, it can be fairly benign and then be fairly explosive. How do you make that call, and has that evolved in the last couple of weeks?
I think it's evolved a little bit with our increased ability to test. So I think when there was a lot more uncertainty about sending somebody home and not testing them and not knowing if they had COVID or not, it was much more unclear, and it was very confusing for patients. And so I think there was a lot more anxiety around sending people home. Now that we're able to test, get results back more quickly, and have established a really good follow-up system for our patients after discharge, you know, we follow, I would say, the same parameters that we do for people, other people that are coming to the emergency department. You know, if you need to be hospitalized because you're hypoxic or have a big pneumonia, or, you know, unstable vital signs, obviously, if you're intubated, then we hospitalize you. And if not, we can send you home, we send you home.
Interesting. Okay. Maybe final question for you is right now is, I'm scratching my head about where all these other patients have gone.
Oh,
I have not heard a good answer to that. I completely get that we canceled a whole bunch of surgeries and other procedures, but as far as I can remember a month ago, and it's hard to remember, the ED was packed with really, really, really sick people.
Oh, yeah.
And they were septic, or having MIs, and it didn't seem optional that they could just have those things at home. And
yeah.
Now, at least in terms of the people you're admitting, there are very few of them upstairs, and I imagine you're seeing fewer of them too. So first of all, tell us what your experience is, and second of all, I'd love to hear your theory on where they went.
Yeah, that's our experience. Our volumes have dropped by over half, or half, depending on the day, and that's typical of pretty much all the emergency departments across the Bay Area, and I would say even across California. Most are seeing extremely reduced volumes. The patients we are seeing are sicker, you know, really people that get quite sick and actually need to come in. And I think part of what's going on is it is the surgeries, fewer surgeries, no post-op complications, you know, not as many complications that you might see from chemo and other things that are being sent to our ED by outpatient providers because the visit volume is probably down. The other thing, I've thought a lot about this, is, you know, you don't have people going outside and sort of subject to the things that happen when you go outside and are active. So maybe that person isn't walking up that hill and getting chest pain and realizing that maybe they've got you know, an LED blockage, or maybe that person isn't playing basketball and, you know, landing the wrong way and breaking their ankle, or maybe, God forbid, people are at home alone and they don't have a loved one there, realizing that they may be having a symptom of a stroke, for example. You know, because a lot of that depends on other people being around. Maybe people are falling at home and we have no idea. So I think it'll be interesting to see what happens when we sort of loosen this, the mandate that's in place right now for sort of stay at home. Will there be a lot of deferred care and deferred need?
Deferred maintenance, as they say.
Yeah.
All right, let's turn to Niraj. And by the way, we're going till 1:15 for those of us watching live. So obviously some people may have to go, but hopefully people can stay. Niraj, you found yourself at the in the middle of an extraordinary position. Really, you kind of led the command center in the early days, and I don't know what could ever prepare you for that kind of swirl of activities and pressure and fear and balancing all of it. Just tell us what it felt like, particularly in the early days when you realized you had this role and you were responsible for processing a massive amount of information, dealing with uncertainty, fear, existential dread, and trying to come up with new policies everywhere and manage everybody's angst.
Yeah, thanks, Bob. In many ways, now that we're ending our 9th week of the command center, ironically, in thinking about this town hall, I had an opportunity to actually sit and do a little bit of reflection with Adrian Green and James Banan in the command center this morning, because I think we haven't probably spent enough time actually just thinking about what the 9 weeks have been like, particularly on a personal level. It's so easy to continue to outpour just seeing the amazing organization this is and everyone stepping into helping solve problems with so many people underneath every initiative and program. But I think the personal part of it has been really impactful. I know for those of us at the command center, you know, Russ as well and Matt Walden, I think just an incredible deep sense of feeling both grateful that we've been given the opportunity to serve the organization this way, but also deeply responsible for leaving every day and worried about what's going to happen. And I'm not sure I've been in a circumstance, you know, other than for a couple days or being on service where you leave that undifferentiated patient and you go home and you spend most of your evening worried about what you don't know and what's going to happen to them, that this has been sustained for such a long period. I think the broad theme, and then certainly, again, happy to blend both reflections from the command center and some personal examples, but part of what you shared is we talk a lot about leadership in times of uncertainty. And I'm not sure we really, I think I have a whole new meaning for what that feels like now than prior to the last 9 weeks. And I think part of the leading through uncertainty, we've used the metaphor that it feels like we've been flying a plane that we've had to build, and we don't have a roadmap of how to build it. And so I think a lot of Maria's reflections of those early days, I mean, the 2 anecdotes I'll share, just really going back to those early days. One, I actually went back yesterday to look in my email and search for terms like virus, Wuhan, to see when was the first email exchange I had about this. And some of those emails have not aged well, like many of the comments from back in January about how much this was going to impact America. But I had an email exchange in probably the first week of January with Debbie Eco and Amy Nichols, just, hey, and the email subject title was literally Wuhan pneumonia. Hey, we hear there's these cases. Is this something we should be worried about? You know, a week later, Josh emails because he's on a call with UC-wide saying, hey, this thing seems to be emerging. Are our infection prevention teams prepared? And of course they were. And just amazing that I go to the Super Bowl weekend. So people may not remember this that well, but Super Bowl weekend, in some ways, with apologies to the 49ers fans, the gift we may have been given was the 49ers losing. If you think about what happened that weekend, had the 49ers won and there were parades and parties at that time, that may have had impact that I haven't seen actually described. It's a date that I will never forget because the Super Bowl Sunday was actually the night that we stood up formally our command center. And the reason for that was another, it's funny to call it a gift, but the gift of we had 2 of the first patients in the country that required hospitalization, and they arrived in the middle of the night. I will never forget sitting in that ambulance bay when those first 2 patients rolled up, a husband and wife who looked terrified because of everything around them. And it also forced our organization to we were in the game quickly. And within 5 days, we became the regional and national experts on how to do this because everyone else was 3 to 5 days behind us. And I think that reflected just the pace of information, the misinformation, and things we've struggled with. And so I think what I'll end with is we also were really clear early on that we wanted to try to be focused on 3 broad goals. And Maria articulated one of them really well, which is how do we safely care for the patients who have COVID-19 with the same compassion we care for others? How do we actually keep our workforce as safe as possible? And the third, which of course is always a challenge, is how do we communicate consistently and transparently throughout this process? And so I think the 9 weeks has been certainly a journey, and where we are today is very different than where we were a few weeks ago. And certainly the next couple of weeks will bring different problems.
So I just looked up, February 2nd was Super Bowl day, for those who have forgotten it. And yeah, take us through maybe the couple of hardest decisions that you had to make in this role.
Honestly, but I would say I'd frame it around what others have experienced. And, in some ways, this is no different than watching a Q&A board during a town hall, that George could be stating something and 2 minutes later, there's someone who's on Twitter who's putting a new piece of information out. The pace of information change, the rapidity of it, the misinformation, and also the uncertainty made it really, really hard to achieve those 3 goals. So the examples I would give on things that were difficult, and Maria remembers as well, those first 2 weeks of even coming up with clinical guidelines and how we consistently care for those patients in the absence of clarity from guidelines was really challenging. And we were on calls every day with the CDC and the DPH and learning from the other handful of patients that were in other hospitals across the country. And I think that period of uncertainty that hasn't gone away, but was really acute and uncomfortable for us. I think similar, as Maria touched on, the PPE, I think, is probably maybe one of the best examples of what is not unique to UCSF Health, but challenging across the country, where you're balancing in some ways a Venn diagram that is the infection prevention evidence for what we believe and how the virus is transmitted. There is the supply shortages and how we make decisions for today, but also be making decisions for the next several weeks when we weren't certain about whether we would see the surge that it appears that we're avoiding. And then the term I think that's been used by many is the psychological science. And we say that because it's real, And, Maria, again, gave an example of how do we balance the tension between what we believe to be evidence versus what we believe to be everyone's individual experience with this. And everyone wants their risk to be as low as possible. And that's different for an individual. And so I think I think one of the other principles we've tried to practice in the command center, I think we learned this very early on, was meeting people where they're at. I mean, trying to be really patient and compassionate and recognizing everyone's impacted by this crisis in different ways at different times, that where someone may have been 2 weeks ago is different where they are now. And so I think some of those difficult decisions were really managing all of that information, then trying to also be clear on why we were making decisions. And, we all recognize in times like this, trust is everything. And so you're trying to build trust because you want to be able to openly state, we wish we had all the information to make every decision. And what we're trying to do is make the best decisions that we have information for what we have in front of us today, recognizing information may be different in 4 hours.
One of the things I think we've been rightfully praised for is the level of transparency, not only inside the organization, but outside the organization. Was that a concerted decision? Did all of you sit down one day and say, we're going to be comfortable reporting numbers and things like that? Or did that just kind of happen and then everybody said, oh, it's the world is not ended, and actually people seem to appreciate that and it's filling an information vacuum?
Yeah, I mean, James, Adrian, and Cynthia Krapa may have a different memory, but my memory is we talked about it very explicitly very early on. And part of Link to the Trust is we felt it was very important to be as transparent as we can with the information we knew. Again, I think the challenge early on is we could have communicated something at noon, and by 12:15 it was outdated. And if people were reading that at 4 o'clock, not recognizing the time we sent it, it would look like we were hiding something. And that actually happened a lot. And so I think this idea of trying to be as consistent with the communications, we didn't do this perfectly early on, and I'm not sure we're doing it perfectly now, but I think we've tried to be really intentional on creating different vehicles and different forums to present information in different ways. And, Russ shared an example of some of the data that we're continuing to put forward. But I do think it was an intentional decision. We really wanted to be as transparent as we could. And, you've heard Josh on every call try to at least share, this is what we understand about our PPE supply today based on what we're using today. And that number can change dramatically in a day if we change what our policy is. And so I think we've tried to do that as well as we can.
No, I think we've done it extraordinarily well, and I think it's led to a level of trust that kind of helps everybody get through a lot of uncertainty. Let me move to some of the other folks, and by the way, if you have questions of each other, feel free. George, some questions about the universal masking policy out there. Is it evidence-based? Is it the right move? And does it, when does it end? After a vaccine or sometime before that?
I thought I was going to get to answer yes to all the questions until you got to the last one. The National Academy of Medicine has been doing quick letters or review letters. They reviewed these masks yesterday. They have come up with some evidence base to suggest that it. All we're trying to do is keep your viruses inside of you, right? So there is that screening, that barrier does cut it down to a certain extent. They said to background rates, and it's a well-written letter. It cites half dozen articles, and there's actually some research that was commissioned specifically for it. So I think that's the answer to the question. Yes, there is an evidence base. Yes, when we move away from shelter in place, we're even going to want you to do that more. And going out into the future, I think once if we can get out to a vaccine, and after we're in a vaccine, I think the masks go away. That's the solution here is having massive background levels of immunity.
But what if we reach a point in, let's say, in the fall where the sort of new case rate in the Bay Area is essentially zero? I mean, we're out there doing enough testing that we're confident in that. Obviously, it does not mean it will stay zero, and the borders are permeable. People come from other places. But can you imagine a sort of prevalence rate that falls below a level where we say you can begin relaxing the restrictions on crowds or the masks or whatever the thing is that we needed now?
I think it's, this current seroprevalence is probably about 0.5%. So it's hard to see us getting up too much by the fall if we're successful. Now, it could all blow up next week for all I know, and we could go up to a much higher prevalence. But at the kinds of prevalences we're talking about, even in Wuhan, it's only 2 or 3%. It's not. We're not really talking about a time and a place where we can really tolerate large amounts of transmission. Now, if the transmission's low, that's another issue. But it's not. That's a reason to relax because the transmission's low, not because we have built up any degree of immunity in the population.
Yeah, and maybe last question for you. The narrative, and I've been part of this, is the things that worked in the Bay Area and California were all of the policies, and other states were later. There are other states that were late that have done fine. Texas being the most prominent, I think. What do you think about that? Is there an element of luck here, or why are certain states dodging the bullet at least to some extent, and they did not do some of the things we did?
Well, first of all, you don't know they've dodged the bullet yet. It's still moving towards them, and I would not be surprised if it blew up. We say what's the difference between California and New York. I think we get asked different questions. I get asked what's the difference between New York and California all the time. It turns out, as from research today, that there were probably multiple introductions into New York from Europe, and so they were starting with many more chains of transmission. Plus, there was one individual who was a super spreader. Again, not a pejorative term, but just a fact. Who probably infected over 100 people right off the bat. Each one of those becomes a
super spreader means that you have a particularly nasty virus, or you have a particularly, is it
don't know
person?
Anatomical, immunological, social, virological, probably not virological, probably one of the others.
Interesting.
But anyway, you're in a position to infect a lot of other people. They're just excreting higher virus titers. And he infected 113 people right off the bat. Each one of those becomes a chain of transmission. So the load in New York to start with was much higher than it was here. So that's kind of a matter of luck. However, we did go to shelter in place earlier than New York did, earlier than the rest of the state did. As Russ said, it takes a tremendous amount of political courage to do that from our elected leaders. And we shouldn't forget that's who's making the call. It's not some effete sort of public health decision.
Yeah.
These are real, these are real complicated decisions that have basically killed the economy for a couple of months. But the benefit is saving 15,000 lives, whatever it is in the Bay Area.
Yeah. Russ, as we move to this new phase, are there digital tools that you're particularly excited about in terms of being able to do contact tracing digitally, to enforce quarantine digitally, know people's movements, looking at Google searches for flu-ish symptoms, those sort of things? What excites you about this today rather than if this had happened 20 years ago?
Yeah, those are things that one should be careful about being excited about. I think one of the things George mentioned was the use of data to look at sort of the macro level movements of people and to better understand the transmission dynamics. I think there's probably a role for that even in, for lack of a better term, the Western democracies, for the use of those kinds of data to understand the flow of people and potentially the flow of contagion. I would be surprised if we do the sorts of things that you've seen in Singapore or China, some of which George mentioned. And then lastly, the location data that you get from a cell phone, maybe it could tell you that you were at the Safeway, but it's not going to tell you that you were in the produce section and coughed on somebody. So I'm actually somewhat skeptical that those sorts of data will be useful for the individual level contact tracing, so much as they will be for the epidemiology. I think there is lots of interesting and I think creative things to come about. We talk about home monitoring and Fitbits and all that jazz, and much of that, in my opinion, has come to not much until today. I think the remote thermometry with Kinsa is one example of, this was not what it was designed for, but it is becoming very interesting, as George described, and I think we're going to see a flurry of activity of people thinking about things that are analogous to that will bring us completely novel sources of data.
Right. Maria, you had to transform the emergency department in about 10 minutes. This is sort of an analog to Russ's question about the video visits. What do you think when this is over, what will be different about either the culture or the processes in the emergency department than it was before we started? What are the sort of enduring lessons or ways we do work that you think will stick? And you're still on mute. You're on mute, if you can take yourself off. There you go.
Okay, sorry. I was going to say, good question. So I think the importance of the need for centralized communication and transparency has been huge for us. So just like Niraj was alluding to, I've really struggled too to think about when do we put this information out, because what if it does change in 8 hours and we don't want to deluge people? So coming up with a system to really keep things up to date and transparent. And then I think just the clinical operations of our department have changed and will probably stay this way. So I think this is going to be with us for months. I'm envisioning us keeping our PPE on for months. It changes our practice a little bit because we're reusing it. We have to be very conscious of where we're putting it and how many N95s we have, et cetera. And then I think our tents operationally will probably, our ACUs will remain up for some time from an operational standpoint. But I guess the biggest thing is the way that everybody in our ED has come together. We're really sort of multidisciplinary specialty when you think about it. Techs, nurses, physicians, APPs, our clerks, like everybody has been a part of the decision making around this. And I think it's brought us together. So that's maybe a silver lining.
Great. Niraj, I'll end with you. You've been in, you're too young to remember Walter Cronkite, but I remember the country needed a voice of reason and calmness in the middle of the chaos. I think you've served that role in many ways for all of us as we watch the town halls and the command centers. What do you think are the enduring lessons for this, for the organization, and how do we be sure that we keep the sort of, we've made decisions and done things in 2 days that would have taken us 2 years of process. How do we keep the good part while we hopefully can look at COVID in the rearview mirror eventually?
Yeah, I hope it's more than a single lesson that we're going to take away from it. I mean, one of the reflections we've had quite a bit, and we've tried to be intentional around, is the COVID-19 preparedness and planning has highlighted many of the amazing strengths of our organization, and it's allowed places to accelerate rapid change quickly. And Maria and Jahan and the ED are a great example of that. It's also highlighted some of the areas where our organization has struggled. We're a large, complex organization. We have lots of silos. And I think many people reflected that when we singularly focus on one priority, it's amazing what we get done in a really rapid fashion, and silos get broken down and people are thinking outside of their vertical area, thinking much more horizontally, including a number of people like myself, Russ, and others who have changed their jobs. Like I actually sadly haven't even thought about my day job in longer than I'd like to believe. And so I think that some of the lessons are, how do we take the benefits of how we've learned to work together? There's been lots of trust built, relationships built across silos, problem solving, people building different skill sets because they've been forced to. And how do we really talk about prioritization in a potentially different way? I think it's something we always struggle with as an organization. So I think it's one of the many lessons. And the last one I would share is just to recognize, I think grand rounds like this and others have done an amazing job to highlight so many of the people in this organization, from our amazing infectious disease faculty and a lot of our clinical leaders. But I think I've also been struck by, I almost hate to call them the unsung heroes because none of this happens without them. So if you use the example Maria gave of the tents, our facilities team made those tents happen in like 3 days. They converted 15 long in like a couple days. And we think a lot about the work that happens underneath. And the story I'll end with was, you know, in the first week, James Banan and I went to the environmental services huddles, 100 people in Cole Hall in the morning and evening, folks who help keep our facilities clean. And in addition to that, are an extension of our infection prevention. And what was being asked of them and their own safety was remarkable. And I remember vividly, one of them actually stood in the room and said, why did we agree to be the institution that would take those 2 patients, those first 2 that came on Super Bowl Sunday? And their colleagues answered for them. We took those patients because we're UCSF, and this is what we're meant to do. And I think that sentiment has been shared like across the organization in ways that have made us in the command center continue to feel like we want to serve and do everything we can to help keep everyone engaged and supported for it. So I hope many of the lessons we've learned are how we have the capability of functioning as a really large, complex organization, recognizing there's a lot of work we're not doing that we'll need to come back to, but how we can do that in different ways.
Great.
And I neglected to mention facilities. I mean, it has been unbelievable what they have been able to do for us. I mean, none of this would have happened with our ACUs or much of the other things without them, with people in the supply chain. I mean, it has really been unbelievable. So we're very grateful.
Well, thank you, because I think that is one of the lessons, you know, these people, the facilities supply, I mean, who thought about supply chain before until it becomes almost a life and death issue? HR, you know, really remarkable to see the organization pull together and what everybody's done. So let me dismiss all of you with my tremendous thanks for not only being part of this, but for everything you've done to help us get through, as it has been extraordinary, and thank you for taking the time to share this. We will get this up on YouTube in hopefully about 4 or 5 hours with an address that I will tweet out tonight, and we'll make more generally available later. And while COVID is a thing, you can plan on a grand rounds covering different aspects of it every Thursday at noon. So we'll plan on another one next week. Hopefully we'll be able to stop these eventually as it becomes less of a dominant issue for us, but for now it is. So thank you all for tuning in, and be safe and be well, and thank you for all you're doing. Thanks to our speakers and our panelists, and also the production team who's listed on the slide there. Doing these things via Zoom is not for the faint of heart, and so thank you all for making it work, and be well, and we'll be in touch soon. Thanks so much.